Now, moving on to our next session, Pediatric Rapid Maxillary Expansion and Myofunctional Therapy. We would like to invite Dr. Joby Peter as a speaker for this session and Dr. Muhammad Sajid, orthodontist and dentofacial orthopedician from Myofunctional, to kindly chair the session.
Dr. Joby Peter, a prominent figure in dentistry, is the founder and driving force behind Online Dentistry, a platform that offers comprehensive training to dentists both offline and online. Recognized for his expertise, Dr. Peter has delivered more than 160 guest lectures and organized 110 CDEs. His research primarily focused on myofunctional therapies in obstructive sleep apnea, along with studies on deproteinizing agents, antimicrobial extracts, and preventive dental care. Over to you, sir.
Good afternoon all. Good afternoon. Yes. Now, I have to ask you some question. Yep. You need to look into this slide. No, nobody asked question, right? You ask question to me, no, but I'm asking you some question. Look into this slide. Tell me which among the character you think are more prone to disturbed sleep disorder or sleep apnea. A, B, C, D. Which one? All of the above. But prominently, which one do you feel a chance of going D, right? Because the neck circumference, the chubby face, this is exactly what 200 years back Charles Dickens mentioned in his famous book when he saw one guy who was sitting on the corner, Tom or Joe, who was sitting on the corner, and he was dozing off in the afternoon. Keep on dozing on afternoon. And he mentioned in his Pickwick papers, first time in the history where child sitting daytime sleepiness was reported there. It is in 1837. Oh God, that guy is again going into sleep. And after that, this syndrome, this came as a syndrome, and we call that Pickwickian syndrome. All of you know about that. So it was originated from the child sitting and sleeping. That was not good. Now, there is one more character in this, which is, again, which ma'am has already told, has a high chance of going into sleep or disturbed sleep disorder, is that long face syndrome. The vertical face increasing. Children with long face, they are mouth breathers and they have a high chance of disturbed sleep disorder there. That is what Dr. William Hill in 1889 said, snoring and restlessness at night is a cause of backwardness and stupidity in children. Dr. Will's famous statement in his article there. So, child should rest at night and sleep minimum 8 to 9 hours. Sound sleep for a child is very important. A group of artists were asked to assemble in a hall, and they were asked to paint a window. Everybody started painting. They painted beautiful windows, different type and style. Out of the 50, one artist painted a window like this. What was it? He painted a window with what he's seeing outside, the beautiful field, the scenery, out of the box concept. He was there. And he got the prize because he focused onto the window at the same time, what we can see outside window. So my dear friends, it's time for us to think out of the box. From the conventional unidisciplinary approach to multidisciplinary approach. Multi-center, join together and give the best for our patients there. Let's see how we can do it. A patient was reported to us, 10 years of age, reported to us from an ENT center, reported to us, and she had mouth breathing, disturbed sleep disorder there. We take disturbed sleep disorder scale. That was around 86. So we again sent them back, and we suggested them, we convinced them. They did an adenotonsillectomy was done because it was enlarged. Significant sleep disturbance was there. If our lateral surf itself showed a adeno and tonsils were enlarged, even the tongue is low posture, mouth breathing is present, the lips are parted at rest. You can see all features we can see there. So she has done adenotonsillectomy was done, and after a month she reported back, and again we did the sleep scale test. So there was a significant reduction in your entire sleep disturbance. From 86 it came to 53, it was very good. Parents are happy. But you can see still the child opens the mouth and sleeps. Now our aim is not 53 is not good. Our aim to reduce under 25. That should be our aim for the better sleep of the child. So we re-evaluated it, and what is happening? What is the reason for it? Then we found out there is something there in the literature. If you see mouth breathing, nasal disuse, and pediatric sleep disorder breathing, Christian Guilleminot, he said mouth breathing is one of the primary cause of pediatric disturbed sleep disorder. Mouth breathing persists even after adenotonsillectomy. And OSA, in patient with OSA, mouth breathing persists even after adenotonsillectomy. So that is why it is persisting. You cleared the nose, but why it is persisting? What is the reason for it? Again, Christian Guilleminot, he has told that adenotonsillectomy may not resolve complete obstructive sleep apnea in children. It's again a very structured article. This is a retrospective study. Around 500 children they did of age group of 7 years. Adenotonsillectomy resulted a significant reduction in AHI, but only in 30% of the child. Rest of the 70% persisted OSAs in children there. So what could be the reason? Even though you cleared the nose, you cleared every aspect of it, what is the reason that they are still continuing doing it? This is what ma'am said. You have to look out of the box. When you ask the child to say ah, don't say ah. Tell them to say E. When they do E, you will know the teeth are coming out, the bite is proper or not, you will know. So first ask them to say E, no ah. And then you tell them to say ah and put the tongue depressor and see the posterior part of your oropharynx there. Why don't you just ask them to say E and see the teeth are aligned, correct or not? So these are the reasons, because hypoplastic maxilla is one of the reasons, and which is very evident with dental crowding, transpalatal width, height and depth of the palate and length of the palate. All those things is our parameters, we will look it, but these are the parameters which can cause or cardinal signs or warning signs which can give you a palate which is constricted and the tooth doesn't have space there. The normal in mixed dentition, in children, it should be in the range of 32 to 38 millimeter. We check always what is the transpalatal width after the first permanent molar erupt. If it is less, it's a warning sign. We look into the depth of the palate. Very important, the depth of the palate. It should be around, ideally in adults, it should be around 42, but in children, there is a variation. There is a percentage variation we can find out. If the palatal height is getting deeper, not a good sign, because it encroaches into your area, not our area alone. It encroaches into the ear. So instead of looking into this posterior part of the palate and the tonsils, I think you should look into the architecture of the maxilla and its size and its width. You should look into that. Look for the face, starting when the patient sits in front of you, whether the patient is having a long face, whether there is a negative, a concave face, the lower jaw is coming out, upper jaw is inside, kind of things are there. The malar process, the maxilla is flat. You can't see anything. You can't see the bulge. Usually we have the bulge, but some children you can see it's very flat. That's again a sign of maxillary hypoplasia that is happening there. So look at that long face, flatness, and the negative bite that is present there. When you look inside, invariably in a small maxilla, the arch will be crowded, and the narrow palate, reverse bite, negative bite, and a deep palate will be visible, which are a warning sign that even the anatomic form of the maxilla could be problem there. So guys, now what you see is, when you look into the coronal section, you are very expert in the ENT part, but let me tell you, we are dealing with the entire complex. What is that complex? It is not in dentistry now we never call it maxilla. We call it nasomaxillary complex, because it's connected to 9 bones. Maxilla is connected to 9 bones. So it is like a nasomaxillary complex. Holistic approach we need. And as ma'am said, your floor is our roof. Okay, roof of the palate is your floor. So, but the problem is, the nasomaxillary complex are connected, interconnected. There are sutures, and these sutures need to be molded. You meant to say that if I expand maxilla, the surrounding sutures need to accommodate the stress and able to bend and keep in pace. So that is why I tell you that what time is the right time to do it. So if you expand maxilla, definitely the floor will get widened, and 0.5 mm of expansion of the nasal floor, the nasal resistance reduces 4 to 5 times. So that helps for you in patients who has got nasal resistance or difficulty in breathing through the nose there. So why? Because young child, 3-year-old child, if you take the skull of the child, you can see the sutures are wide open and there is cartilage in between there. There is nothing else. Cartilage, growth potential is remaining there. But that is immature suture. But as and when it goes high, you have problems. So the sutures up to 3 years are not fused. There is probability, but it's very tough to do expansion for a 3-year-old or difficult there. But the window of opportunity is 3 to 15 years. That is our window of opportunity where the sutures start getting fused. By 15 and above, the sutures completely gets fused and it's very tough to break those sutures. As ma'am said, you have to do surgical approach. You need heavy forces or alternate approaches are there. But our window of opportunity is 3 to 15 years. I will show you cases how we treated there because this is very difficult to split open. So I would say if you want to do treatment for maxillary expansion non-surgically, 8 to 10 years would be the ideal time. If the patient are more cooperative, you can even start 7 years also. But in my practice, 8 to 10 years, it's an ideal time. You get the surgical split open with the non-surgical approach, you get there. Because the sutures are immature and see, they are interconnected. So you touch maxilla, the surrounding bones also take up the stress. They need to be molded, bended, accommodated, adapted. So that is why early when the sutures are immature, you do it, you get the best expansion and best result. You get the full face development there. So maxillary transverse hypoplasia, which madam's already talked, sagittal hypoplasia. So we expand maxilla, we protract maxilla, and we have a combined approach there, which we will discuss there. So I'm going to discuss about non-surgical maxillary expansion there. Now, if you see this article where in cases where maxillary hypoplasia was expanded with RME, what was the result? You can see increase in the volume of nasopharynx and velopharyngeal area. The CBCT study showed there is a significant improvement in the nasopharynx and velopharyngeal volume of air that going there. So when you need to expand, it is a method of gaining space for us, but in a small maxilla and medical reasons of OSAs or disturbed sleep disorder, we can expand maxilla, it can benefit us there because it improves nasal breathing and improves the volume of air there. What are the types of expansions we do? There are 3 types of expansions, but I will be concentrating on orthopedic expansion, non-surgical orthopedic expansion called rapid maxillary expansion there, where we expand with the help of the appliance, which already ma'am, so I can go faster here. Because this is an appliance which is placed inside, we take the support of the tooth or the alveolar structure and we turn it and we get the expansion. And we confirm the expansion with the help of a occlusal view radiograph where you can see the sutures will be split open and it will get, bones will get filled off in between there. So that's the beauty of rapid maxillary expansion. High arch, constricted arch, when you expand, you get a wider arch for the tongue to place there. So cases where the transpalatal width, I told you, it was around 38 mm should be, but you can see it is reduced, high arch palate, and we expanded. You can see how it is expanded and brought into almost 37 to 38 millimeter there. So how do? We keep it this expanders and then we teach the patient do turning the screws with the help of the screw which is given there. So every day patient will turn. We have a protocol for expansion there. And we have 2 types, banded and bonded type of expanders, which we have a case selection protocol as that. These are expanders we use there. Then once you expand, you bring the maxilla out with the help of a face mask, which is attached onto the face and chin of the patient. And patient wear in the night with these appliances, a 3 to 6 months duration, can bring the maxilla out. Now, see this case, if you can see a negative bite, you can see a negative bite. The mandible is going down, vertically going down, long face, and the posterior airway space, if you see, it is less. This is the negative bite, and we did rapid maxillary expansion, protraction. You can see the posterior vilopharyngeal area or the posterior airway space, you can see. But after expansion and maxillary protraction, you can see the difference in the amount of space created, and you can see the direction of the mandible has become more horizontal because of the expansion and the protraction there, and the posterior airway space improved drastically there. So, adenotonsillectomy and orthodontic therapy in pediatric obstructive sleep apnea, if you say children who had rapid maxillary expansion had a significant decrease in AI from start of the treatment to T1 after the treatment there. So rapid maxillary expansion is always a good alternative tool. A dentist can help you, support you when you have children with AHI cases there. So what we are doing it, we are just expanding the maxilla. What is the fundamental principle of this? Is a Bernoulli principle. You are expanding the maxilla, you are reducing the nasal resistance, making it less resistance, easy for the child to do. So the resistance to sleep, the snoring, everything drastically improves with this there. What is this? A dog's tail, right? There is a saying in Malayalam, Pattida valu pandirandu varsham കുഴലിട്ടാൽ നേരെയാവില്ല. Any Malayalis, if you don't understand, let me tell you, if you put the tail inside a hole 10,000 years, it is going to straighten up. Same way, it is not going to correct unless he decides you are going to correct it. These things will never get corrected by itself. Yes or no? It will never get corrected by itself because it's a, what is it? Habit. It's a habit there. So, this guy, Dr. Joby Peter Harwold, has done one experiment which is very famous. He stuffed the nose of the monkeys. The monkey opened the mouth. He kept the monkey for 3 years. The monkey nicely lived by opening the mouth. And he removed the plug, but the monkey has learned a new behavior pattern. The muscles got adapted to a new behavior pattern, a neurological pattern established on the monkeys. And monkey retain the open mouth posture even after removal of the plugged nose. So because it is 3 years he's been stuffed, so he learned. So the muscles automatically postured the mandible ah. The lips automatically opened up. The tongue automatically came down, and all was registered in the brain. So the neuromuscular adaptation happened. So you do adenotonsillectomy, good. You have cleared it. But by the time the child is being 7, 8 or 9, 10, there is a learned behavior pattern that has happened, which is already registered there. So even if you remove, some improvement will be there, 100%. This I already told you, but not a permanent solution. It is not fully corrected because there is a behavior pattern that has happened there for the muscles to hold and open up the mandible, to posture the tongue there. I got only 20 minutes, sir. Your 30 minutes was my time. Fine. So the morphological response to changes in neuromuscular pattern experimentally. This is a beautiful article, you must read. What madam said is, this is a beautiful one, but I will summarize down. The neuromuscular changes were triggered by complete nasal obstruction. Believe me, nasal obstruction causes the behavioral changes or the neuromuscular changes. So you are one person who have to correct it. Without that we can't. But after your correction, now the changes in the neuromuscular recruitment pattern resulted in change in the function and posture of the mandible, tongue and upper lip. Who are supposed to correct that? We have to correct that also because they are all controlled by muscles. So we dentists and we have to gel together. We are actually two sides of the coin. We have to gel together, work together. Whichever patient needs this need to be given. Some patients get automatic correction, but not all. So, habit. You remove H, what happens? A bit will remain. You remove A, what happens? Bit remains. If you remove B, what happens? It remains. Habit is like that. It's not easy to break. Okay? It remains there. So, habits is like that. It remains there. So, mean to say that if you need 300 repetition to form a habit, then it takes 3,000 repetition to break the habit. So, it's not easy. It's not easy to do that. So that is called orofacial myofunctional therapy. OMT is coming into the picture there. Do it daily. Do it yourself. Myofunctional therapy is very important because studies says that you need orofacial exercises. When you after adenotonsillectomy, when you do orofacial myofunctional therapy in moderate obstructive sleep apnea, not severe. Severe form requires a different protocol. Please, mild to moderate obstructive sleep apnea, there is increased oropharyngeal muscle exercises, significantly reduces OSA, severity and symptoms. And these are the results. Even neck circumference, there are neck muscle exercises. People with a huge fat deposition along the neck, diet will control, but there are specific neck exercises which help them to reduce that. Snoring, all those things reduces the orofacial myofunctional therapy. This is again from ASSM, where they have protocols. It's a new chapter, it's a new innovation, and it's going to change the future of treating people with disturbed sleep disorder, because it can play a very important role there. So myofunctional therapy to treat obstructive sleep apnea, systematic review and meta-analysis. Myofunctional therapy reduces AHI by approximately 50% in adults and 62% in children. So myofunctional therapy plays an important role. Playing windpipes. This is again, it's a simple. Tell the child to do pee, do it. Let them play it. It's good. It actually makes the child to use the diaphragm, the deep inside, diaphragmatic breathing, not neck and shoulder muscle. You can't poo pee with that. The diaphragmatic muscles. So all those things, it's a study done. All those things improves your diaphragm, which improves the use of the inspiratory and expiratory muscle, not the neck and shoulder muscles there. And double reed wine instruments, all. These people, they did a study on these people and they found out that they do not have snoring. They do not have disturbed sleep disorder. They sleep well because they have very good diaphragm. The muscles of the holding the breath and all those things for them were very good. So that is why if you see the latest protocol of different phenotypes of OSA and the treatment of OSA, the one must unavoidable thing is oropharyngeal exercise therapy. If there is persistence in oral breathing, you have to go for oropharyngeal muscle therapy is there. So this is young me, long back me doing the deep myofunctional exercises. I will show you the simple myofunctional exercises. Is we teach them to take breath. We see them how they are taking breath. If they are using neck and shoulder, we teach them, no, that's not the right way to take. Use your tummy muscles. Ask them to keep the hand above your tummy, belly bottom. Ask them to keep the hand above the belly bottom. Ask them to cough. When they cough, you can see pouncing action. That is your diaphragm. So your diaphragm, they analyze them. Then ask them to take breath in and out. So it should come out, it should go in. Come out and go in. And no neck and shoulder muscular movement should be there. And alternate nose, like alternate nose. So we tell them to seal the lip. We ask them to seal the lip with the micropore tape and breathing exercises. Teach them the belly bottom, just above the belly bottom is your diaphragm, and then tell the child to take breath. Deep inhalation and exhalation has to be done there. Lip seal, ask them to seal the lip and go to sleep. So there is a protocol for that to do that. So that is also done there. Different types of lip sealing is done. So these are the myofunctional exercises. Nasal breathing, swallowing, facial exercises, tongue exercises. I will be concentrating on some about the nasal breathing exercises there. The myofunctional exercises we do. Button pull, tongue spot, tongue suction, tongue click and chew exercises. I will show you some video demo of some of the major exercises and some appliances that we use there. So puffing air between cheeks. You ask them to puff air between cheeks. Hanumanji exercise we call. Hanumanji exercise. That's also very good exercise for them to strengthen the lip muscles, because their muscles are being atrophied. They're hypotonic at this point of time because long period of time. So we tell them to do these exercises to strengthen the lip muscle so that the lips can be postured normally at rest. So that will be done there. Then pop sticks, or you ask them to use the pop sticks and then take a breath, holding the lips together and taking breath. One nose you ask them to do, and then you can alternate to the other nose there. So you can ask them to do these exercises there with the help of pop sticks, holding the lips together. You can even ask them to use a paper. Paper holding is also good. Ask them to close the lips. Our fundamental aim is to seal the lips and take the breath through the nose. And then comes button pull. Button pull, a decorative buttons are available. You can get from any craft shop, a big button. You tie it with a string and then ask them to use the lips. Ask them to pull it out, but use the lips to hold it. So the lips get strengthened there. Button pulling exercises are done there. Then we have appliances like oral screen or myo brace, or so many appliances are there. We ask them to wear these appliances and not just go to sleep, but wear the appliances. And with these appliances, we ask them to put it inside, and using the holding, you ask them to pull it out. So that your lips, you can see the tug of war. You can see that your lips will get nice, the upper lip and the lower lip get nice pressure, and it gets strengthened, so the hypotonicity of the lip goes. So there are oral screen, there are trainers, there are functional appliances are there. Functional appliances are there. And then we go for tongue training. We go for your bluegrass. There are some appliances which we use for training of the tongue. So what is the training of the tongue? We ask them to find the spot. That is very important. Can you find out the spot? Spot is your incisive papilla. The papilla where the incisive papilla, that is the tip of the tongue should be resting on the incisive papilla. Tell them to identify the spot and press against the palate. Tell them to identify the spot with the tip of the tongue. And press against the palate. Very good exercise to expand palate for young children. So that is first thing that we tell them. And then you ask them to press against and do a click sound. It's not a kindergarten, okay? But this is one beautiful exercise. We teach them to identify the spot, press against the palate, and release it. That's against the tongue. So cases you can see with this, with the hypertonic thing, you can see how the change that happens with the help of myofunctional exercise. I'm done. Myofunctional exercises will help you to develop the face. Any kind of faces you can develop without or with the support of appliances with the proper myofunctional therapy there. All those things are cases which we apply, we can see there. So that is done. Fine. This is a testimony. This is a patient who came to Al-Azhar and was referred to me, and I treated this. Sound connection undo? Illa. So it is already done there. He had a constricted arch, severe sleep disturb problem. Academic performance was very less. Because of this, and we just did a simple expansion for him, and after the expansion, his academic performance, sleep, and most importantly, his behavior pattern drastically improved. What is happening? A tiger inside a cage. Let me tell you, you must read this textbook. Everybody must read this textbook to understand the importance of ENT and dentistry. It's a 6-foot tiger inside a 3-foot cage. You need to make the cage wider for the tongue to rest there. Your tongue rests at that spot, the tip of the tongue and rest of the tongue. So in order to rest, you cannot have a constricted arch. You need a wider arch for tongue to rest. So that is our fundamental principle. So all of you are welcome to my college, I know Dental College, which is only 20 kilometers from here. And thank you so much for this wonderful session. Thank you.
Thank you, sir, for that wonderful session. I would now like to request Dr. Gifty Zacharias, Consultant ENT Specialist and Head and Neck Surgeon at St. Mary's Hospital, to kindly felicitate the chairperson, Dr. Mohammed Sajid, and our speaker of the session, Dr. Joby Peter. May I request Dr. Gifty to kindly felicitate our speaker of the session, Dr. Joby Peter.